Hi friends, today we'll be discussing related to OBGYN paper 2 which consists of majorly gynec. So we'll see out what is the exam pattern. So the detailed analysis of what is Bloom's taxonomy is already done in our channel. Make sure you visit that part of the YouTube and know what is actually Bloom's taxonomy. So basically we'll jump into what are the 5 parts what university has given. So I have arranged in order based on the number of questions in which they have asked. So the maximum number of questions is being asked in part 1 and part 2, that is CIN or malignancy part and infertility and PCOS का thing. Then you have puberty menorrhagia का thing. Then it's mostly about genital injuries. Then the vaginal discharge and infection part. So basically if you see it's either first thing is about the malignancy ka part. Then you have infertility part. Then you have in general patho ka part. So the major two things which you need to learn extra from the core pathology thing is your fistulas and the prolapse thing and the infertility thing. So if you have an idea on how to go about this, and obviously operative topics has to be integrated. So if you have an idea on all these things and how to go about it, we can see how we will look forward in how to place the diseases in such a way that so we don't get fumbled out during exam. So long answer question. So first question and second question. So basically this is always more important than the other part. So one question related to malignancy is sure. Either you might get a CA cervix question or a CA endometrium question. Okay. Then second question related to infertility is almost sure. Otherwise, or you might get a prolapse related thing or a part 3 which is AUB or DUB, something which you get which you will get for sure. Then one essay, short essay related to PCOS is damn sure, and one related to infection, that is PID, will come, and one question related to your infertility management, for example semen analysis, tubal patency, related to that thing one will come. Then also something related to fibroid or endometriosis is something which might come. Then related to operative methods, either hysterectomy or C-section, something related to that will come. Then fistulas and injuries related one question will come. Then something related to contraception they might ask you, and related to amenorrhea and things. Okay, short answer question basically something related to investigation ka part and to operation related ka part. You might get 4 questions something related to that. Then one thing something related to hysterectomy for a 3 marker is a sure question. Okay. And also one thing related to infection, then anatomy and course of ureter and the lymphatic drainage. One thing related to pharmaca drug, something they can ask, and dysmenorrhea and menopause. So if you see this has an easy narration, not like obstetrics, for the fact because you know the pathology, the core pathology, you just need to place it and come back. So firstly, if you see under part 1 we will be studying about the malignancy. So these are the chapters which is there under Singhi or Datta. So based on this we will plan how to go about it. Okay, from 33 to 39. So firstly it's 37, so that includes all these conditions. So here what I have done is I have added few extra points. So I am cutting down on things which are not important and just presenting you the things which are important. So now any malignancy related things, I will just provide you a general template so that you need not remember everything. Okay. So this is how it goes. Whenever you are talking about the malignancy ka part, so while writing clinical features, make sure you write general and systemic. In this you write local and you write pressure symptoms and due to metastasis. Okay. So do local symptoms, you'll write it accordingly. For example, hydronephrosis or those things. Then again, while writing pressure symptoms, divide it into urinary bladder, rectum, and due to metastasis, either you might get due to lung or due to liver. Make sure you present it accordingly for everything so that you know what you are going to write. And again, investigation cutting, investigations to diagnose the condition and to look for complication. Okay, so that's how in a general thing which I would like to fit in. Okay, again coming to this part, again etiology and risk factor, it, again goes in the same thing. See, again whenever it comes to hormone related things, which are the two things, endometrial is the one thing which is hormone related. So related to that you can write about the risk factor. And I'm sure in pathogenesis you need to know metaplasia later converts to dysplasia, so they either lead to neoplasia. So this is the general sequence, right, for related to any squamous cell disorder. So you know any organs, any structure which is exposed to environment, for example your mouth or your oropharynx or your the anal canal or near the vagina, you have squamous cell, stratified squamous, so that since it's bound for injury, so uh, the cell layers get shaded down. So that's one important thing which you know. So based on that you will write out the things. And again histologically it can be either squamous cell, adeno and adenosquamous. Again as I told, clinical feature, make sure you go with the same thing which I have taught. And by writing stages first, I'll come to the stages later. Again you might get a postcoital bleeding, and again to mention about this, then again due to metastasis ka thing which I have discussed, again to screen. And one thing about to confirm, this is the same thing, I'm not explaining much. Again while coming to FIGO staging, mention stage 1, stage 2, stage 3, stage 4. Under stage 1 you have to mention the fact that confined to the cervix, here extend up to upper 2/3 of vagina, here loco-regional disease, here distant metastasis. And A is something to do with your proper either rectum, bladder, and B is to do with superficial inguinal lymph nodes. Okay, so again you have 3A, B and C. We'll discuss lately, but at least if you cannot learn the whole staging, make sure you learn this subheadings. Okay, stage 1 confined to cervix, then upper 2/3, then loco-regional, then distant metastasis. Okay, yes, then loco-regional you can mention this, correct. So again treatment I will explain you in a general way. So from 1, so these are the stages. So for convenience let me classify it as this. Okay, only 2 and this thing I'm doing for a fact, because see, for example, if it's from 2B to 4A, directly you go for chemo radiation. What does chemo radiation mean? First you give a chemo and sensitize it, and then start with brachytherapy, that is radiation. Okay, so from 2B to 4A this is the only treatment. And if it's from 1 to 2A, you go for surgery, and for 4B you go for palliative chemo. So this is the general idea. So based on that I've given you the notes. So make sure you study accordingly and place the disease and come back. Then CIN2, this is the major thing. Okay, you need to draw the diagram, and also treatment is based on whether fertility and the age factor. So based on these two things you need to check whether it is important, what has to be planned. Again, screening for CS cervix, it's an important remarker. So make sure you write all these things and classify accordingly. So this is the major thing which they will ask. Either you can do obviously this is something called as co-testing. So this is what is preferred, and if you get positive here, then you go for visual methods. Then these are the visual methods. And related to again what is the concept of visual method is, you are applying something and you are checking the chemical reaction occurring there, and you are checking whether dysplastic cells are there or not. Okay, so again colposcopy related things, what is the important thing which you need to mention? You will check for any abnormal vascular pattern. Okay, then what is Werthin's hysterectomy? Okay, so this is upper 1/3 of vagina and medial half of parametrium. So when this is being cut, okay, so this is called as Werthin's hysterectomy. Okay, with pelvic node dissection also. So make sure This is there's nothing for me to explain here, so I'm just again, I hope you know types of hysterectomy. You have one, and you have two, and you have three, where in one you just remove the uterus, but in two, that is what in hysterectomy, you also remove upper one third of vagina. Okay, and three is much more radical. Okay, regarding the conization of cervix, again you need to know the indication part of it here. Again, it can be either for diagnostic to check for whether CS cervix is present, and for therapeutic itself also, you can in stages 2 and 3 you can cure it. And also when you need to excise the margin for assessment, those are the miscellaneous causes. These are the techniques. Okay, then this is the major important question. As a part of 10 marker, they will ask you causes of postmenopausal bleeding. So make sure you present it accordingly. Now draw a diagram and label all the parts. Then classify it as benign and malignant for these three conditions, or you can classify for that in any way. And also broadly, when you are talking about bleeding, what I have taught in other videos, you have to talk basically with traumatic and non-traumatic, and also mention one important thing, that is systemic, under which you will talk about coagulopathies. But coagulopathies are usually rare in the postmenopausal. It can be a secondary something, secondary coagulopathy, coagulation disorders. Okay, then as I told, these are something to do with hormonal. Metabolic itself can affect the hormonal thing. Okay, this is the classification where this is estrogen that is hormone dependent, and non-hormonal dependent. Again, clinical feature, make sure you follow the same template which are given. Again, investigation, again to diagnose and to stage it. Okay, so basically based on the staging, this is the staging. It's important to know. So what happens in stage 1, it is limited to the uterus body itself, that is confined to the corpus uteri, that is uterus. Here the cervical stroma is not involved. Okay, but in the third stage, what happens is you will have the again, as I told, it's a local regional disease. Again, when it comes to C, it is pelvic and paralytic, but 4B is what? 4B is superficial. Okay, superficial inguinal nodes also. Again, A as B1, B2. If you feel it is complex, make sure you study the first subheading of under every disease. Okay, and this is the treatment protocol which has to be done. I've just mentioned it, so you also mentioned the same. And this is about the prognosis thing. So what is fractional curettage? You are taking an endometrial sample to do a check for any pathological conditions. So you can mention all the conditions which are present. What is corpus cancer syndrome? So this is nothing but the present day I hope you know that there are genetic syndromes. For example, in some condition, endometrial carcinoma can be, if in less than 40 years, if it's present, then you need to also expect some other carcinoma like colorectal carcinoma, which comes under some other syndrome. So before they diagnosed this syndrome, they named it as corpus cancer syndrome. Okay, so these type of questions are reduced now. Okay, now coming to the benign ovarian tumor part. So again, this is the concept map. First, to understand what are the tumors which can be present, again, first you need to know what is the surface epithelium made up of. Again, it can be based on that, you might have surface epithelial tumors. Then again, germ cell is there. Then again, sex cord and stromal are there. Again, you have metastasis cutting. So based on that, you need to derive everything from it. Okay, for example, in this case, you can see surface epithelium. Either it can produce serous thing or mucinous thing, or it can have an endometrioid kind of cells, and also you can get clear cells and and also Brenner cells. Then also germ cell. So again, I have explained what germ cells will do in your OBG itself. Again, you need to imagine the embryology part. After the zygote is formed, what are the things which forms yolk sac, embryo, then placenta, then at the end, what does teratoma connect? All three germ layers. And again, sex cord stromal tumors, these are the things. Again, make sure place the clinical features accordingly, and this is one of the important things in an old age woman. Any recurrent gastritis not resolving to medication for 1 year need to be evaluated for ovarian tumors. And these are the investigation. This is the management. Basically, you need to talk about optimal cytoreductive surgery. Then complications of benign ovarian tumor is an independent 5 marker. Make sure you study it. There's nothing for me to explain. Again, if it's more, again, you can either go into rupture or hemorrhage and infection and torsion. Again, this is what we have discussed earlier. Again, dermoid cyst contains all 3 layers. Okay, basically you need to worry about torsion, that is complication. So all complication of benign tumors you remember, and make sure you mention the same thing. Okay, so Brenner's tumor, what is B? So here you will remember bean. What is bean? Coffee bean nuclei is present. So based, that is the microscopy. So again you will have the same thing. Okay, dysgerminoma. So what you can remember? How do you remember that dysgerminoma? That means it is a dysplastic cell. Okay, so again you know that in a hemolytic anemia LDH is increased. So again you can think of something related to dysplasia, right? So again you can think dysgerminoma LDH is elevated. So these are the same thing. Okay, then again staging of ovarian malignancy, this independently can come as 3 or 5 marker or a 10 marker. Make sure you study the proper thing. Okay, again FIGO staging, for this I don't think this is required, but you can just mention the, you can just study the first thing. Okay, this is an important remarker. While writing ultrasound ka features, make sure you divide it into morphology, Doppler flow, and what are the associated conditions. Okay, and granulosa cell tumor, while writing, make sure you draw this graph so that you know what are the major thing which you need to mention also. Important thing is this. In Krukkenberg's tumor, make sure you write about the prognosis in this part. And Meek syndrome, what is the important thing? Don't study, don't write about all this pathogenesis thing. So pathogenesis thing, see, it's an independent 3 marker, right? So you need not mention about it. Make sure you write about clinical feature. What is the triad? That in itself is a 3 marker. And if you do the management of thecoma or cystadenoma, then the concept itself will resolve. Okay, the pleural effusion itself will resolve. What are the 3 components? Pleural effusion, the ovarian tumor, and the ascites part. Both will get resolved if you treat this. Okay, so tumor markers, I am sure as the same concept, go with the same things. First divide and write what are the things which are present. This I have explained in one video. Then beta HCG, obviously where do you check? In pregnancy. So what is present? Placenta is present. So make sure you study that. And also dysgerminoma, I have told you how to remember it. Then again, what does Leydig cell produces? Androgen. But what does what does inhibin do? It gives a negative feedback, right? So GCT is producing estrogen. So the marker for that is inhibin. Okay, so this is an important 3 marker also. So make sure you study this also. Then again gestational trophoblastic neoplasia, this I have given you the concept. So for example, as I told in other video that I have explained in this thing, so what I am doing is the thing is, see, in a normal pregnancy you will have both fetus as well as the placenta. So never confuse between what is complete and incomplete. So what does complete mean? See, complete means completely it is paternal. So you have mostly placenta ka thing. So concept is paternal chromosomes helps in chorionicity, but maternal chromosomes helps in fetal development. So you know now why. So this is the spectrum. So you can see that first you might have a molar pregnancy. Either you can have complete mole or incomplete mole. So complete mole means the sperm itself goes in an empty egg where there are no maternal chromosomes and it gets duplicated. But incomplete is everything gets fused. So after that, if it's confined to uterus, then it is called as hydatiform mole. But once it starts evading uterus, it is called as invasive mole. But once it invades beyond the uterus, then it is called as choriocarcinoma. So now you know why complete mole has increased risk of choriocarcinoma. Okay, so now you know the concept, fit it into the place and come accordingly. Okay, again invasive mode, as I told, when that is confined to the uterus itself. So again I have told you the pathogenesis. Make sure you remember the clinical feature. Again the same thing. So as I have told, it's the same metastatic workup. You have to go see. The major important thing is this is the follow-up thing question which they might ask. So while writing follow-up, you have to write about 3 things: biochemical follow-up, clinical follow-up, and to monitor the treatment protocol which you have issued. So clinically, obviously I have to ask for all the thing. Okay, for example, whether she's having any vaginal bleeding or uterine involution, and biochemically after, and also have to address about the contraception, that she should not conceive, she should not get conceived because it's already she's already going through the GTN spectrum. And again you have to talk about contraception and OCP ka barrier. And also one more important thing is you have to call, you have to first measure baseline beta HCG at 48 hours, then you have to call or for follow up every week until you get the until you get beta HCG which is undetectable for 3 consecutive weeks. Okay, this is the main thing. So, and what are the abnormal things? They will, if you ask, you can just mention it. Then again, based on the protocol, you can mention about the choriocarcinoma also. Again, radiation therapy is an important 3-marker question. As I told, from 2B to 4A is where you use radiotherapy in CS service, but there are other things also. What is brachytherapy? Brachytherapy is you are inserting something. Okay, so what you are either you can insert it to the cavity of the uterus or you can place it as an interstitial thing. But what is teletherapy? Telephone or television you are doing with some, you are using some in a far way. So here if you have the machine which is emitting rays, here you might have the patient. So this is called as teletherapy. Brachy is you are inserting. Okay, that is brachytherapy. And these are the indication, as I told. The same thing you can write it as for proper therapeutic purpose, for adjuvant purpose, for palliative purpose. Okay. And again, but complication is an important remarker which they have as acute and chronic. So make sure you write all the things, and while writing acute, make sure these are the important things which you mention. Okay, then related to all you can write, but these 3 is something which is important. Okay, that's it. This is about the CIN or malignancy ka part. Now you know what to study in order so that you have an idea, because this is like a sure 10-marker question or a 5-marker question, and 3-marker you can expect something related to tumor markers or something related to your GTN ka follow up or something related to radiotherapy. Now you have a definite idea. And also I have discussed briefly what are the specific questions which are asked with respect to only this section, because I had made a video in the last year. So make sure you watch that video first so that you have an idea what you are going about. So I formed a general template. So based on that, I have presented you with the things so that you have a proper idea. Again, now coming to the section 3, which is the next important thing. Here PCOS is the sure 5-marker. One question related to PCS is like sure, and infertility related question, if you are not getting under 10-marker, under 5-marker you will get 1 question. Then again also it is a plus or minus 1 question you will get. So basically these are the chapters which is there in Singi, and this is what we have done. This is there in one more video. Make sure you go and watch it. So let us jump into the infertility part of it, since it's an important 10-marker question itself. So what is the important thing which you need to study? It's only based on, for 5-marker you get interpretation or analysis or tubal patency type of question, but for infertility ka 10-marker thing you might get causes or how do you evaluate a patient. So again, definition is important. These numbers you need to remember. Then what is primary? That means she has never conceived, but secondly she had conceived now, but now due to some other problem she is not able to conceive. Again, these all things to make sure you omit it off. Okay, then again, main factors, how do you divide? Again, first write the testis. Again you might have post testicular cause or testicular cause and pre-testicular cause. So based on this you need to divide and you need to mention accordingly. See, I have mentioned here. Again, here you can divide it into hypothalamus and also pituitary. Again, you can mention all about Kallmann syndrome or pituitary tumors or prolactinoma or any trauma. Again, here major thing is you have to talk about genetic conditions like Klinefelter syndrome and also infections. Okay, mumps or orchitis, and also these things. Post is basically you have to think about obstructive thing. And also 2 more important things which all will forget is again semen abnormalities like oligospermia, teratospermia, asthenospermia. All those things you need to mention. Then also he might have coital tension. It's the coital problems or functional problems which also should need to be mentioned. Again, while coming to female thing, again make sure you write all the structures which is present there, and again write down all the possible things which can block. So basically first thing which you have to discuss about is tubal. Then you need to talk about the ovaries. Then you need to talk about the uterus, then the cervix. Then at the end you need to talk about peritoneum. Place it accordingly and make sure. I hope you know this WHO classification ka part, which we'll be discussing in ovulatory infertility. Again, based on FSH, LH, you need to classify it as 1, 2, 3. Again, during management thing, I'll come and discuss that. Okay. So evaluation. Now, how will you go? The major thing, first thing is you have to do 2 semen analysis, start to twice to confirm. Okay. And again, for endocrine related things, you do hormonal, again divided into pre-testicular, testicular and post-testicular, and the semen analysis cutting. Since semen analysis problems are more, first you need to talk about that. Then the endocrine part, that is here you are talking basically about pre-testicular things, so you need to talk about this. Then again here what you are talking about, post-testicular, again you are talking here about testicular, then any anatomical abnormality. So study accordingly. Now you use the classification which are studying. Again, female thing, again you need to know what are the things which are present. Obviously one endocrine related thing you will get. Again, what is the important ovulation assessment which you do, that is AMH. Then this is the uterine thing and tubal thing which you do. Again, treatment, write it as general and specific, because few people, when they follow general protocol itself, some people can get conceived, but these are the specific things which you need to mention also. And again, the WHO classification of ovulatory infertility is something which is based on if hypothalamus failure is there, or if ovaries are normal, or if ovaries has actually failed in case of post-menopause. Okay. And again, how do you treat ovulatory infertility is what we have discussed. So you need to stimulate the ovary, for which now we use letrozole. Okay, then you need to give an HCG trigger which mimics LH. Then you need, otherwise if even after this, if the patient is not getting conceived, then you need to follow other protocols, that is artificial reproductive techniques, like based on what is the problem, whether it's problem with the male partner or female partner. If it's with male, then you go with ICSI. If it's female, then you need to go with IVF. Again, if it's not happening, then you need to go with ZIFT or GIFT, that is zygote intrafallopian transfer or gamete intrafallopian transfer. In prognosis, again, semen analysis, I have written everything because it's an important thing. So make sure first broadly you divide it into negative symptoms and positive symptoms. Now again divided into 3 2 1. So remember, what was the first thing, this is the general thing, that is you need to talk about volume, you need to talk about pH and the sperm concentration, but this is the main thing. Okay, that is sperm count and motility and morphology, and this is about the viability, that is almost 50%. I don't expect you to remember the exact numbers, but at least somewhere near to that you should know. Okay, then these are the negative things, that means you should have less than 1 million per ml of WBC, then also 5 million less than 5 million round cells, and it should have less than 10% spermatozoa for agglutination. So this might you might be overwhelmed by saying this, but make sure you know what you are writing, and divide it and then study. And these are the indirect tests. This was RS2 kind of question, even this thing, so make sure you just study upon. Again, what are the drugs used in induction is what again I have told you about the letrozole, which we use it nowadays, that is letrozole 2.5 mg. Then you need to monitor, then you start her on HMG, then you need to again at that time you need to also add progesterone, okay, because you need to stabilize the uterus. Okay, and also these are the biochemical abnormalities and adjunctive medicine which you need to use based on the endocrine profile. Okay, these are the objectives. And if you have time, if you ask me, you need not study this. Okay, it's not an RS question. Then semen analysis ka interpretation, obviously first you need to give the general advice on how to collect the sample. And again, this is an important thing which you need to mention. Again, while writing about interpretation, divide it into broadly about the morphology, about the sperm count, and about the mobility. So based on that, you need to place the disease and and you need to give the interpretation. Again, surrogacy, last time it was a 5 marker, so I have just mentioned it. So you just need to go about it. There's nothing for me to explain it. Again, saline sonography, this might come as a 3 marker question. Okay. Ectopic gestation I have discussed in the obstetric part of it, so I am not discussing. The only thing which is important from gynec part of it is they might ask you the criteria for MCQ, or sometimes 3 marker you might get the same what is Pijlberg's criteria, so you should know it's something related to ovary. That's it. And acute and chronic pelvic pain, this is RS2 type of question. If you have time, then you need to come and study. Again, this is short one question in 5 marker, you'll get something related to birth control and MTP. I'm sure you would have studied in comment, but I've given you the proper notes, so make sure you there is nothing for me to explain here. See, gynec as an easy narration. So if you know your pathology part of it very well, then there's nothing for me to come and discuss. I have placed everything in an order, so you just need to know what are the things which you need to present and specific things and box it and come back. What are the two important things in gynec which you need to study extra is only one thing is about the infertility part, which has an easy narration, and second thing the genital injuries or all the prolapse part of this prolapse part of that, which has one of the tough thing, but you will have a limited number of questions which can be asked. So make sure you know what extra to study apart from your pre-paraclinical thing. So again, these are the contraindication, again divided into infection, malignancy, then something obstetric related, and these are the related things. Again, complication, I am sure you would have studied in your pharma, I am not discussing, or and also about the missing iudica management, important, you have to it is an important 3-marker question. So what do you do? First you have to exclude pregnancy by doing a UPT, then you have to do a pelvic examination. You have to check whether you can see the string. So if you are unable to sing, then then you have to use a TVS cat, and again if you are unable to see a string over there, then you need to take X-ray, then you have to see where it has been migrated, and you have to, if not possible, then obviously at the end you have to go with a laparoscopic removal. But if you can see, then you can use alligator forceps and you can remove the IUCD based on the location where it is. So make sure you study accordingly. Then again, this is a 3-marker thing. Again, while writing non-contraceptive use of OCP, this is all definition, though this might come, but the major important thing is you should know what are the uses. Okay, again, all conditions in gynec you can write. Okay, and here again some cosmetic related thing and all the systemic condition. Again, if you have time you can study, otherwise I don't encourage you to study. What does mini pills? So there is no estrogen in mini pills. So these are the injectable contraceptives which are there. I am wantedly not discussing all things for a fact that these are some things which you have studied from second year and third year. There's nothing for me to discuss here. Only infertility and genital injuries is what I'm discussing. Then emergency contraception, again divided into non-hormonal and hormonal. So this is the best thing. If she has already passed the 14 days ka cycle, that is half of the cycle, then it's always better to use copper IUCD. Otherwise, again you have all this uriprestal, then combined OCPs and LNG pill also. Then this is about the interval thing. Then also Pearl index, yesterday also I studied, and comet also. I'm sure you would have also studied in comet. Again, complication of vasectomy, again divided in any surgery, I already write intra, post-op. Again you have early and late. So based on that, these are the major important things which you need to do. So make sure you place it. This is a proper 5-marker question. Okay, so they might ask you what are the methods. So firstly, you have, first thing you can remember about the SR method, where you via hysteroscopy you go and put that is the copper containing thing which is present like this, so it causes fibrosis. So the sperm will the sperm might not migrate. Then what are the laparoscopic thing which you can do? Either you can do tubal ligation, or you can just put alka clips, or you can put a ring. So based on the tubal ligation, again you have Pomeroy, modified Pomeroy, Parkland technique, and this alka clips which I have discussed earlier. So what do you do in Pomeroy? You just ligate it. Okay, and exercise the fallopian tube. But what do you do in modified Pomeroid is that you are going to you are going to have a smaller loop which is being excised. But what you do in Parkland is that after doing ligation, you are going to bury the proximal tube deep under the myometrium, so that you have least chances of pregnancy. Again, if it's done after 6 weeks postpartum, it is called interval sterilization, and if it's done from within 48 hours to 6 weeks, it's called postpartum. And these are the complications. MTP I have discussed in obstetric video, so make sure you study it. PCOS in and out for 5 marker you should know. So again, the definition and this is the clinical feature. So basically you need to talk about everything. So a patient might have cosmetic problem, or she might have reproductive problem, or she might have metabolic problem, or at the end she might have psychological problem. So you need to place it, and you need to discuss the management protocol also regarding that. Then Rotterdam criteria, very important. 3 major things about the androgen excess, either clinically or biochemically, or you might also discuss you can discuss about second component is about the ovulatory dysfunction, where you will have oligomenorrhea or secondary amenorrhea. And major thing is, make sure you remember all the numbers, that is more than 12 follicles of 2 to 9 mm or 1 centimeter ka size in one or both ovaries of volume of more than or equal to 10 cc. Okay, and also you should rule out CH. In management, as I told, first is lifestyle. Then you need to know what is the primary thing. If she has hirsutism ka problem, then you need to address laser. You can use laser thing. Then if she has infertility ka problem, obviously first general measures. Then you can try for letrozole. But if she is having menstrual irregularities, then you can start her on OCP or progesterone based on what is the cycle, whether it's regular or is irregular, and whether if she has systemic complication, then obviously you can try metformin. Then these are the consequences of PCOS. So basically you need to start with short term and long term. Again, in that you have to divide it into systemic and ops. Okay, in systemic, obviously we will talk about all the metabolic things, and also CVS, again this is linked to metabolic. And reproductive, again you will talk about the endometriosis part and also the psychological. Make sure these are the 3 important things in obstetric which you should know. Okay, so again I'm revising PCOS because for a fact I know this is a 5 marker. Again, while writing clinical feature, based on patient profile, you need to discuss all the clinical feature. Then you need to talk about Rotterdam criteria, where you can clinically say that she is in an androgen excess state by either biochemical demonstration of high testosterone or the hirsutism, or you can second thing is you need to have a sonographical evidence of where you will see more than 12 follicles of 2 to 9 mm in either 1 or 2 ovaries of more than 10 cc. Then important thing is about the secondary amenorrhea. Then you should need to address all, and also you need to have 2 out of 3. You need to address all the management, all the necessary concern of patient of PCOS, but also by writing consequences, what I told, again you have to write it in short term and long term. Again, short term is more related to gynaec thing, and long term is almost related to systemic thing. Okay, so make sure you present it accordingly. And hirsutism, either 3 mark you might get. These are the causes. So what is the concept of hair being grown? Either you should always have androgens. So wherever is androgen excess, you can also mention about hirsutism. Obviously in PCOS, what is there? Testosterone is high. Again in CH, what is the high? Testosterone. Hypergenic like danazol also. And it can be idiopathic. Then this is how you go for a diagnosis and investigation is basically endocrine related investigation. Then this is the major thing which you need to mention. Functional ovarian cyst, always these are the again, if the dominant follicle doesn't rupture, it will cause follicular cyst. Then if corpus luteum undergoes hemorrhage or enlargement, it causes corpus luteal cyst. Then again theca luteal cyst, what is the major 2 things which you need to rule out? Again, you need to rule out whether if pregnancy is present, because it's due to beta HCG, and also any GTN or even multifetal gestation for that matter. Wherever beta HCG is high, you need to rule out this condition. Okay, that's it about part 2. I know I have not discussed much for the fact that because I don't want to discuss everything because it's almost 150 or 175 pages. So I'm saying you what are important, and you can just go through it. Again, part 3 for 5 marker or a 3 marker. This is an important topic. Okay, this is what I will be explaining you. Remaining thing I am sure you can go and discuss. Again, I will just explain you the concept. So for prolapse, to understand prolapse, you should know what are the levels of support which is present in uterus. I am sure which I have studied in anatomy. So I get level 1 you have ligaments ka support, level 2 you have muscles or fascia ka support, level 3 is your perineal body ka support. So based on this, what is anterior colporrhaphy and posterior colporrhaphy we will discuss in the coming slide. So what is majorly while writing management of prolapse, first you have have to check what the age of the patient, that is the parity, and also whether she wants fertility or not. Based on this, our management will be focused on. So for example, if the patient is very young and she's unfit for surgery, obviously you just do a conservative management. But for example, if the patient is a young woman who has completed her family, obviously you can go for Fortgrill's or Manchester operation, which is an important thing which will be discussed. Shirotkas is also something where you have learned in obstetrics, you have learned it in cervical incompetency, correct. But if it's an old patient and fit for surgery, again is all nothing but PFR, that is pelvic floor repair. Okay. And also young woman who is nulliparous and wants to conceive for uterus, you need to have a sling surgery. So for that you need to understand the supports of uterus. So what do you do in Purandare surgery? Again we have to you will do a sling in the posterior rectus stage. So P for P. What do you do for Shirotka surgery? At the back, that is at the sacral promontory, you are going to do a sling. And what do you do in Khana surgery? You will do it in the ASIS. Then what do you do in vertical surgery? This is what we do. Okay. So this is extra edge. If you want, you can just remember, but this is an important thing. Okay. This is again the same thing. This is not important for your boards at all. Okay. Make sure you don't see for now. Okay. Because we cannot waste time. Obstetrics, though it has the extra things, the number of amount of thing which you need to study in obstetric is less when compared to gynec. So study what is only important. So these are the things. So again, I have discussed you with the supports of uterus, and again how do you go in a third degree prolapse in a 26-year and a 60-year-old. So this is the support. I have discussed it already. Then diagram, if you want, you can mention about the POP-Q classification. I have not mentioned because I am not going to write it for exam. Okay, these are the stages. Again, first, what is the reference point here? Again, if it's more than 1 centimeter, it's stage 1. Then from 1 centimeter to 0, it's stage 2. Then if it's completely out, that is called as procedentia. Then again, third degree prolapse in the 26-year. What is the goals? You need to preserve fertility, and also you have to spare the uterus, for which we will do Fortgrill's Manchester, where we are going to do cervical elongation. Then we need to support it. But in a 60-year-old lady, what you will do? If you are going to remove the prolapse uterus and also correct vaginal wall defects, and you are going to prevent the wall prolapse also. So what is anterior corporaphy? You are going to correct the cystocele. Posterior corporaphy, you are going to correct the rectocele. Again, if she is unfit, you are going to do a ring procedure. Then genital prolapse is the classification. I'm sure if you just even see, you will understand it. There is nothing for me to discuss because I have already explained you the concept. And clinical feature. While writing clinical feature, think about all the related organs or structures nearby. So then you can place the clinical features accordingly. These are the investigations, all things you need to read on. Okay, make sure you present it. Okay, these are the differential, and this is the management, and this is the post-operative care. Again, Fortgrill's operation is something which is asked for 5 marker repeatedly, so I have mentioned it. So again, what is the principle? You are going to amputate the cervix and attach the cardinal. You are going to plicate it and increase the support for cardinal ligament. Okay, that's the important thing. Again, this is the basic step, and this is important. What we do is, first, to prevent hematometra, we go with dilatation and curettage. Then obviously, since it's an elongated cervix, you are going to do cervical amputation. Again, you are going to plicate the McEnroy's ligament to increase the level 1 support. Then obviously, you need to treat the other vaginal wall defects like cystocele, rectocele. So we go with anterior colporrhaphy, and we will also do perinorrhaphy to repair the rectocele and perineal body. So you are aiming at all levels ka support. This is what is important for Fortgrill's application. Okay, these are the complications. As I told, from what I am saying, while writing any surgical operation, the same thing. So not discussing. In decubitus ulcer, you need to talk about the major thing. What people is, you have to rule out cervical cancer. So make sure you talk about that, and it's a conservative thing. But major thing is, again, if it's old age and she's fit for surgery, do a PFR. Otherwise, you're going to do a Fortgrill's operation. Again, RS2 question. I have not even written it because I feel it's not good. amenorrhea, again numbers are important, 15 and 13. So again, if she has secondary sexual characters and she has not attained menarche from after till 15 years, it's primary. Then no secondary sexual character till 13 years and no menarche, again it's a primary thing. Okay, these are the causes. I don't think I need to explain. Again, use the same concept based on gonad, locate it, and you need to develop it. Primary amenorrhea is never asked for your 5 marker thing. Okay, so don't study it. This is what is given in that. If you want, you can study provided you have time. The major thing which they ask is cryptomanoria for 5 marker. So you can study this. Okay, so again, the management thing, people forget about the counseling part, about the future for fertility. You need to discuss about that. This is the pain management, and also the major thing is you go with cruciate anastomosis, and also the follow-up thing is also important. Secondary amenorrhea is important. So again, make sure you draw this diagram. When you draw this diagram, I'm sure you can place the disease. One thing is, always remember, fertility is related to endocrine. Okay, then how do you do evaluation of secondary amenorrhea? Again, what we do, we have to always, wherever while evaluating in gynec condition, first thing which you need to mention is about UPT. If UPT is positive, then there's nothing more to evaluate, but if it's negative, then you need to start on all those things. First, what is the important thing? You need to check whether it's primed or not primed. If it's already primed, that is, if you have thick if you have thick endometrium, obviously you can start with progesterone challenges, because estrogen is required for priming, for progesterone to act. Okay, so if estrogen is not there, then progesterone cannot act. So first you have to check whether you have to do progesterone challenge test. Then if there is withdrawal bleeding, then obviously you have to think something related to PCOS. But if it's not there, then you have to go with estrogen and progesterone. Okay, though this is just a clinical thing, what we do is we do ultrasound and check whether it's thin or thick. If it's thin, if it's thick, then we think something related to ovulatory infertility. But if it's already thin, then we think that it's a prolonged diseased endometrium. So we have to prime it with estrogen so that progesterone receptors can act. Then again, if there is bleeding, then it's something to do with your if there is no bleeding, then you have to do histoscopy and check whether it's an Asherman syndrome. Otherwise, again related to endocrine, that is, you need to think about above ovary, all those things. Okay, this is about the progesterone challenge test. And Sheehan syndrome, after that, I think you already know the concept. During pregnancy, the pituitary enlarges its size, but the blood flow remains constant. So after postpartum, if there is postpartum hemorrhage, then she might go into postpartum necrosis of pituitary. That will lead to Sheehan syndrome, where you will have absence of all hormones, not only not only related to lactation. That's the main clinical presentation which patient presents. Again, menopausal, it's as a easy thing. I am not discussing anything for a fact, because if you read it, you will understand. Okay. Again, pyometra is something where you have pus. Okay. Again, precocious puberty. I'll just mention what are the things which you need to talk. Again, you need to talk about the age. For boys, it is 9, and for girls, it is 8. And again, you need to talk whether it's true or pseudo, then obviously whether it's complete or incomplete. And these are the investigations which you need to do. This is an important 3 mark. Okay. And miscellaneous condition, this is an important. So this is the major thing. Why treatment ka part, you need to write about all the things. Again, investigation here is to confirm also, and also to look for complications. So make sure you mention this also. Klinefelters, I think everywhere you have studied. I'm not. Mastalgia, make sure if it's non-cyclical, rule out trauma and cyst. But if it's cyclical and related to menstrual cycle, major thing is you have to talk about the medical management. Okay. Fibrocystic, I've discussed in surgery. Then I request you to check for ASRM or WHO guidelines of recent thing. Okay, so based on that, you can have absent uterus, or you can have only one cornea, that is only one thing present, or you might have two things present but it's not fused, but either it's two things are also present but it's not fused at the top, or you might have the septa which is still there and not regressed, or you might have due to DS or DS related cutting where you have T-shaped thing. Then these are the remnants of Wolffian duct. This is an important 3 marker for which you can remember. That is paraferon, epiferon, and Gartner's duct. And while writing bicoordinate uterus ka problems, make sure you talk about all. That is reproductive, obstetrics, and gynecology. Physiology, I am not here to discuss about physiology because from first year you are studying this. Okay. This is all physiology and least likely questions. Okay. Lymphatic drainage, again this is the first chapter which you study in that class, so I hope you have studied it. Perineal body also. Course of ureter, now I don't know whether they might ask, but for 5 marker or the 3 marker it's a very very important topic, so make sure you know it. Again I'll just write water under the bridge. I'm sure you know this from anatomy. Okay. Then the next section, see we have already finished 3 sections and we have completed all the major things related to gynecology. So this is something which you have discussed in WATS. So there's nothing for me to explain. So these are the single questions which are there. Then again dysmenorrhea, again you will have primary or secondary. Primary here is idiopathic. So secondary you will have some other condition, some other pathological condition. Here you need to just give expected management and insights. Same thing. See. So I'm not discussing anything extra from this. Again AUB, you have to remember about the palm coin classification. But definition itself is an important thing. Either AUB can be related something to volume or frequency or duration or regarding the regularity part of it. These are the etiology. Again the same palm coin you can write it for etiology, and these are the differentials. This is how we manage. Again while writing you have to talk about general management, medical management, and surgery. This is the management protocol, again based on the menopausal status. If it's perimenopausal, what you will do, premenopausal, what you do, postmenopausal, what you do. Here you think about malignancy part first, then here you think about irregular, here you think about immaturities, that is irregular cycles. Okay, but here you always think about pregnancy related things first. Okay. Again puberty menorrhagia, again if she has prolonged menstrual bleeding, it's in the early age because of the immature HPO. Okay. Fibroid uterus, this is an important sure 5 marker or 10 marker. So based on, again I am sure if this is mucosa, again you have submucosa, muscularis, and serosa. So I get either you can have interstitial thing or you can have subserosal thing. Okay, that is it. This is the serosa part. Again you can have subserous, or here you have the broad ligament, or you can have somewhere in the it can be a parasitic. But if it's the submucosa, again you have sessile, or you can have pedunculated. This is pedunculated or sessile. Okay, and also you can have fibroids in the cervical part also. Again these are the etiologies. Make sure you talk it with respect to genetic, environment, and family history. These are the clinical features. Though they are picked up in a routine scan, sometimes they can present you with all these things. This is the complication. Make sure about the red degeneration of fibroid, you study properly. What do you do? What is the management for that? It's an expected management. These are the investigation. And this is the management protocol. I would attach the data image at the last, so I am not discussing. Again, red degeneration I have already told. Then myomectomy, what you are doing, you are removing the uterus. So where do you do? Where fertility is needed, or where you cannot do hysterectomy. These are the indications and these are the relative indications. Okay. Again, this is the procedure. Hysterectomy, starting of the video I have discussed, either you will have type 1, type 2 or type 3. Again indication, divide it and write. Okay, see, benign, malignant or obstetric related. Then again while writing complication, same thing which we have discussed in order, make sure you write it. Then endometriosis or adenomyosis ka part. Again endometriosis is what? If you have the functioning endometrial tissue somewhere other than uterus. So these are the theories which are there. Okay, so theories plus environmental and genetic is what I will write. Okay. Clinical feature, same clinical feature you can write about everything. Okay, so this is the main thing which people are forgetting. Everywhere you can write about pressure symptoms. One you see swelling, so make sure you write about the same thing. I'm not discussing because I know these you are presented in your clinical cases. Again, majorly you have to address the pain release, and also if she's planning for pregnancy you have to talk about fertility part thing and also about the recurrence. So these are the preventive measures what you can do, and this is the treatment options which this we'll discuss later. Adenomyosis, when this is there in the myometrium. Okay, what is the major thing you will see in MRI? Bulky uterus. These are the major clinical questions which you, major clinical feature which you know. So this is a triad of dysmenorrhea, infertility, and menorrhagia. Though 50% are asymptomatic. Again, hormonal therapy, I'm sure you will know when to give and when not to give by this part of time. Okay, this was an independent question for 5 marks. Okay, again this is a surgery topic if you ask me broadly. So again you will have, so when you talk about retention, obviously you might have any functional cause or anatomical cause. So anatomical cause is obviously after surgeries. Okay, so might be due to post-operative, which is very common. Then obstructive cause, that is anatomical cause, which we are discussing. Then again you might have if bladder doesn't contract, then also you might have retention. Then also if there is spasm of external sphincter, then you might have retention. And these are the gynec related things. Again, fistulas, I am sure is something which you have to know. So these are the causes, so make sure iatrogenic is something which you have to mention. Then related to obstetric, you need to talk about perineal tears. Okay, that is one important thing. So this is the procedure. I mean, how you do with the swab test, that is the investigation part. And this is the treatment. SUI, I am sure you would have already studied it, so I'm not talking. And this is something to do with surgery part, that is urology. Okay. Though these are not the questions which you expect, I have just mentioned it so that you have a material to study at for exam. In perineal tear, important 3 markers. So either you can have first degree, second degree, third degree, fourth degree. Make sure you know the diagram so that you are going to present it accordingly and you get the full marks. Okay. Again, about the perineal tear, I have discussed already in that class. Okay. The gynaec related things and obstetrical. Then how do you manage? Only after everything is subsided, you will take up for operation. This is one important thing, but I'm sure you would have studied from comment, so there's nothing for me to discuss here. So these are the conditions. I'm just providing you the notes. So abscess, I'm sure you know it. If there's an abscess, what do you do? Incision and drainage. That's the major. Then obviously related to this cystic part, you need to talk about the bartholensis, which is an important thing. Then how do you go about the marsupialization thing, which you need to discuss. Again, pruritus vulvae, that is you're having itching in the vulva, that is something which you need to also discuss. And these are the principles. Then again, this has an easy narration, so I'm not discussing. Make sure you underline things which are important. Then Amsel's criteria itself is an important 3 marker. I'm sure you can you will know what are the things which you need to discuss. Okay, again here, any vaginal thing you need not do partner treatment, but if it's involving the cervix or the pelvis, then you need to do partner treatment. Again, leukorrhea, it's a physiological thing, so that is one important thing which you need to know. Then again, these are the causes, then how do you manage? And senile vaginitis due to age. PID, again you need to talk about all these things. Okay, what are the causes? Again, how do you go about it? These are the complications. And how do you prevent it? About the drugs. Again, TB, wherever you have to talk about the specific symptoms and local symptoms. So make sure you write it accordingly. And ATT, then again, if you have any systemic local complication, again do the management part. This is the investigation. And Asherman syndrome. So what is the main thing you have to do? Okay. So in these things, I have just underlined the important things so that you know what are the things which you need to discuss. So this is what the kit. So remember, I think all of you know vaginal thing is quite safe. So it has green kit, and these are the components. Then this is due to PID. Sorry, this is due to PID, yellow kit, and this is gray kit for cervical thing. And again, for endometriosis, what do you do? Again, you need to address pain and also infertility part. For that, you can just go through it. Again, primary dysmenorrhea, I don't think you need to study, because either you might get the 3 marker for which you need not know the management protocol itself. But for fibroids, obviously, first you need to locate where it is based on symptoms. Again, if it's asymptomatic only, the major thing is again regular supervision. Otherwise, if it's symptomatic, again these are the options which you have. Okay, that's it. See, like obstetrics or any other ortho or medicine, like how I've explained there, I know that I'm not explaining the same order like how I've explained in the previous class, because all the videos, for example, for AUD, for infertility, okay, and also for cervical malignancy, all these videos are present in the same YouTube channel. So again, there is no point for me to explain the whole thing. If you have any doubt, make sure you go to that part and you watch it accordingly. But the problem comes, the major aim for me to say is, make sure you study according to this part, so that you know what you are presenting a day before, what you are studying a day before exam, and you present accordingly. But I have explained you the concepts which are important. For example, I have discussed about the malignancy clinical features at the starting, and also the complete mode, incomplete mode, so that you know have a general understanding. And also the sling surgeries part, Shirodkar or Purandare surgeries, which people get confused, and also the major things which has to be discussed. But the remaining others is almost something related to pathology or surgical topic. So I have not discussed any of it here, for a fact that here the main aim of the video is to make sure you study important topics and not so important topics a day before exam. I hope that is more clear, and study well. I wish you the best. Thank you.